Is a normal spinal tap enough to rule out neurologic Lyme disease? I get this question a lot. This is part of my Common Sense Lyme disease series where I discuss cases I've seen in my practice, issues I've seen in my practice. This presentation follows with a quiz that will address this question. But I'm basing this quiz on a paper by Semi called Lyme Disease Presenting with Interesting Neurologic Features of Weakness and Hyporeflexia. Now in this case, we're going to go through it and then address questions and answers. The case was a 25-year-old woman who had progressive numbness and tingling of the torso and whole body. Part of the reason it got published is that instead of starting in the feet or legs, or maybe hands, it started in the torso, but none of the classic symptoms at the beginning of fever, rash, or joint pain. Now, what caught her attention is that she dropped her toddler due to numbness. When they did a physical exam, they found that actually she had weakness with 3 out of 5 in the upper body, 4 out of 5 in lower, and that's quite weak. And it's pretty obvious by physical exam. And there was a decreased reflexes in all limbs. They did a spinal tap. They found excess protein. Now, in this case, proteins by itself alone are elevated in a lot of conditions. In Lyme disease, they can have a high white count and a high protein count. But in a 1990 Neurologic Lyme disease article, only 2 out of 27 had an abnormal spinal tap. This patient just happened to have a positive Western blot test, and that's Logigian and Steere, where the articles were 25 out of 27 had a normal spinal tap. She was prescribed IV ceftriaxone, which is a pretty common prescription because it crosses the blood-brain barrier, and they follow with doxycycline. And she had a full recovery according to the authors. Her movement came back, her gait came back to normal. So the lessons learned from this particular article was that neurologic Lyme is variable. Instead of always memory concentration as the main issues or autonomic issues, in this case it was a numbness and tingling. We sort of see this in a small fiber neuropathy that shows up in some Lyme disease cases. The spinal tap can be normal. In fact, it's quite normal in most patients that I've seen. And early antibiotics work, at least it worked in this particular case. And it can certainly affect daily life, but in this case it affected her ability to carry her baby. This is a reference by Semi and colleagues. So here's a few questions I'd like to address as part of this case discussion. Is a normal spinal tap enough to rule out neurologic Lyme disease? No. As I mentioned, very few of my patients have a abnormal spinal tap. They might have a spinal tap to rule out other illnesses, but a spinal tap is certainly not a very sensitive measure. What was the first symptom the patient experienced? There's quite a range of symptoms, but numbness and tingling in the torso was this one's presentation. Could be that she had small fiber neuropathy, but if the symptoms clear up with treatment, is that we'll appreciate it, and we'll go to a further workup in this case if there's ongoing numbness. Now, numbness and tingling usually involve a neurologist to rule out other causes of this sensation. Which classic Lyme disease symptoms were absent in this case? In this case, there weren't any of the classic things that you might see in early Lyme. They went on to more of a neurologic presentation. Where did the numbness begin? We often see that numbness begins in the legs, the feet, maybe the hands. But in this case, it was the right side of the lower abdomen in the hypogastric region, which is an area where it's not usually the starting spot, but it led to this publication so the authors could share some of the findings they might not expect. Which neurologic sign was present during the exam? In this case, there was hyporeflexia. That means the arms and legs didn't have the reflexes one would expect. And what caused the patient significant distress at home? That would be when she dropped her toddler due to numbness. During the exam, of course, she was tremendously weak. And how was the Lyme disease diagnosis confirmed? In this case, it was a positive Western blot. It wasn't the positive ELISA. And what was the initial treatment provided? In this case, IV ceftriaxone followed by doxycycline. Now that appeared to work according to the authors, but this doesn't address co-infections like babesia. IV ceftriaxone doesn't work for Ehrlichia anaplasmosis, and the short course of doxycycline isn't as effective as one would like to wrap the therapy up. We tend to avoid steroids. And what was her condition at discharge? In this case, she had full movement, normal gait restored, but 1 out of 3 patients in leading studies still have some chronic issues after Lyme disease. That doesn't mean they can't get treated for a persistent infection, but fortunately she had full movement on their exam. And what did the case highlight about cerebrospinal fluid findings in Lyme disease? And this should be in your comment section. Was it elevated CSF protein is required for diagnosis? CSF may be normal, so clinical judgment is critical. Lumbar puncture is unnecessary, or abnormal CSF confirms viral infection only. So if you leave these in the comments, I'll address those. Thank you for joining me for this common sense Lyme series coupled with quizzes as a way to just discuss the topic. So thank you for joining me. Have a good day.